Well, welcome everyone. We are still waiting for a few more minutes to see if we have any more people to join us. Aaron, do you want to start the work? She did not. She did not. Okay. Yes, confirm. Okay. Six for one. Getting 7 now. It's for okay. We have 5. I was an accident on Saturday watching this. All right, I think we'll go ahead and get started at this point. I'm Lori Mullet, the chair of the Choice Committee, and one of the things of some new responsibilities, recognizing that we have some of our members attending in person and some online, is that we do take a roll call. So please recognize yourself when your name is called. Jim Light, Vice Chair.
Here.
Senator Ed Charbonneau. Senator Lakeisha Jackson. Representative Ed Claire. Representative Carolyn Jackson. Leslie Huckleberry.
Here.
Dr. Joanne Burke, we believe will be back. Stephanie Anderson.
Here.
Welcome.
Thank you.
Beth Schoenfield. Megan Smith.
Here.
Jacob Sipe.
Here.
And Giovanna War.
Here.
Thank you all. We have some new members to the Choice Board, and I'd like to do some official introductions. 2 members or 3 of you are here today, so welcome so much to our Choice Board. Senator Lakeisha Jackson, who will be joining us, was recently appointed to the board by Senator Greg Taylor. Senator Jackson serves Indiana State District 34, which includes the east side of Indianapolis, portions of Lawrence, including portions of Center, Washington, Lawrence, and Warren Townships. We also welcome Stephanie Anderson. Stephanie was appointed as the member representing individuals with mental illness. Stephanie is currently the Chief Operating Officer and Vice President of Strategic Initiatives and Quality Improvement for the Mental Health America of Indiana. Giovanna Ward was appointed as the member representing the direct service workforce. Giovanna is currently the Director of Operations for the Indy Superb Care Agency, while also continuing to work shifts to provide direct services and support to clients. She is a charter member of the statewide Indiana Direct Service Workforce Advisory Board. And Jacob Sepp, though he attended last month, we want to ensure he receives a proper welcome and introduction. Jake is the Executive Director of the Indiana Housing and Community Development Authority. So welcome to the Choice Board.
Thank you.
Thank you. All right. I would like to, though we are still lacking a quorum, I need to have a motion to accept the minutes of the previous meeting, and so it can go on record, at which time when we do have quorum, we'll bring that forward. So is there a motion to approve the minutes of the last meeting?
So moved.
Jim's moved and a second.
Second.
I got you as first, Jim.
Okay.
Is there a second on that motion?
Second.
please? Leslie, thank you. And we do have a quorum now, so all those in favor of accepting the minutes, please signify by saying aye.
Aye.
Opposed? Okay, the minutes carried. All right, would you like to update us on member recruitment?
Good afternoon, everyone. I'm Erin Wright with the Division of Aging. In May, we discussed new positions and vacancies on the board related to House Enrolled Act 1067. And this increased the number of members on the choice board from 15 to 17. So since we last met, we have had new appointments. We welcomed Jake Sipe from IHCDA at the last meeting. And then Lori just introduced Stephanie Anderson and Giovanna Moore. We have applications pending with the governor's office for a provider of choice services for the position that represents that vacancy. We are still in need of applications to forward on to the governor's office for several other positions. We need or have not yet received a nomination by 2 or more organizations for a citizen or I guess a recipient of choice services or their caregiver. That position requires a nomination by 2 or more organizations that represent senior citizens or have statewide membership. We also are seeking a nomination by 1 or more organizations that represent individuals with disabilities, including individuals who are less than 18. We have that vacancy still remaining. And then we also need applications for a home care services advocate or policy specialist nominated by 2 or more organizations. So the vacancies that we have require nominations from organizations. So if you could help spread the word, we would really appreciate it. And follow up to the meeting, I will send the board members the specifics of what kind of organizations we're looking for nominations from. But we're hoping to get all of these positions filled as soon as possible.
You about disability? Disability.
It's on their list. We still need applicants for that one.
Oh, did you mention that one?
I did.
Sorry.
I intended to, maybe I skipped it. I did, okay. So. Okay, thank you.
Thank you, Erin. We now, in July, it is part of our process to have the nominations and elections of our chair and our vice chair. This is my last meeting with the choice board. My husband and I very unexpectedly had the opportunity to purchase an RV and we're hitting the road, friends. So we're very excited about the opportunity. So I wanted to say first, previous to serving on the choice board, I was on the Commission on Aging, and it has been a wonderful experience as a citizen, as a person working in the industry, and working with so many impassioned people for the needs of our elders in the state of Indiana. And so I wish everyone the best as you continue your work, because very soon I'm sure I'll be needing those services. So I appreciate the opportunity that's been given to me by 3 governors, actually. So with that in mind, we do have a slate of officers, and that is Megan Smith has graciously accepted an invitation to consider the position of the chair, and Jim Light has agreed to continue to serve as the vice chair. Recognizing that we are bringing on many new people and like to get some people in place, and then hopefully Jim as well can take a step back himself. So are there any other nominations that would be made forward? Hearing none, may I have a motion to accept Megan Smith as the chair of the choice board and Jim Light as the vice chair?
So moved.
Second.
That's been first and seconded then. So all those in favor signify by saying aye.
Aye.
Opposed?
Aye.
All right, thank you. And I will ask Aaron to come back. Thank you both, Megan and Jim, for your willingness to continue to serve, and look forward to some really wonderful opportunities, Megan, for you as you work closer with the team at FSSA. So
Wonderful. Thank you so much.
thank you. All right, Aaron, please.
I am going to provide an update on the work that we've been doing around a no wrong door system, and Joanna's going to pull up the slides. So while she's doing that, just want to remind you that a no wrong door system is the concept of an integrated, seamless, coordinated network designed to support individuals and their caregivers needing long-term care regardless of payer source. No wrong door includes information and assistance, person-centered counseling, streamlined eligibility determination for public programs, as well as state governance. Next slide. I've mentioned at prior meetings that the Division of Aging received a grant from the Federal Administration for Community Living related to no wrong door system governance, improving access to long-term services and supports for individuals and family caregivers. It's a 2-year grant that started in September of 2022. And a key focus of the grant is the support and development of a governance team, which is comprised of many divisions within FSSA, as well as other state partners such as the VA, IHCDA, and SHIP. So since the beginning of the grant, we've really been working in 2 main phases. First phase, we were mapping out access to services. We did a lot of stakeholder engagement just to try to better understand the current landscape of access to long-term services and supports. And for the last several months, we've been working on developing an implementation plan to address any gaps or inequities or pain points to help Indiana continue to move towards a no wrong door system. We're really working towards this vision that's outlined on the next screen. Indiana will sustain a no wrong door system of access to long-term services and supports. All Hoosiers and caregivers can easily obtain trusted information about public and private resources that support informed decisions and access to LTSS options through a visible, coordinated system. So I'm going to pass it over to Maddie Shea with Health Management Associates. She's been part of the team that has been working on this grant. It's been our governance team, University of Indianapolis, HMA, and other stakeholders have been part. So Maddie?
Thank you, Erin. Go on to next slide. So Erin talked a little bit about the first phase, where we learned that for Hoosiers, it's really difficult to access information about LTSS, LTSS information and resources. And I want to remind you that the LTSS no wrong door system will be in service to people from birth who need long-term care and supports all the way through old age and death. So it's a through the life course program. So you have getting this information is important to individuals as well as caregivers and families. And we learned that the system now involves multiple agencies and funding streams for people with disabling conditions, and that Hoosiers have to navigate all of these systems with duplicative forms, and it's frustrating for them. So in the ideal system, there would be choice, control, and access to a full array of quality services. So this implementation plan seeks to address these gaps and goals. Next slide, and next slide. So there were 4 main areas of focus in the implementation plan. In the first one, state governance and administration, the first goal is to refocus the governance team on the implementation plan and goals so that every member knows their role. There'll be a charter that puts that in writing, and that there's an emphasis on continuously assessing and improving because information changes, and the needs and experiences of community members changes as well. Another goal here is to embed and ensure that the multi-sector plan on aging is aligned with this, that there's like a seamless alignment between long-term services and supports, no wrong door system, and the MPA. Next slide. The next bucket has to do with public outreach and coordination with key referral sources. So the first goal is to develop a comprehensive communications plan so that we know that state program staff, partners, and the community at large can easily access reliable information about the services for which they are eligible. And this incidentally would apply to people who of various incomes. We heard in our interviews that some people that are most challenged might be right above the poverty level, but have, or, you know, not be very low income, but also have tremendous needs here. So I wanted to put in a little plug about that. The second goal is to implement robust training and education for community navigators and frontline staff so that they can actually become enablers of being able to open doors for people they talk with. And the third is to promote awareness and understanding of this system and solicit continuous feedback from community members so that the governance team can understand where there's gaps and develop an approach to prioritizing these in its continuous improvement. Next slide. The third area is to develop and disseminate a training for state staff as well as healthcare delivery care managers who provide person-centered counseling. These are a really important door for a lot of people who need long-term services and supports. So we want to make sure that they're getting the training they need to not just provide information about what they do, but what other programs are and resources are available that can help the person they're talking to. Next slide. And then this last bucket is to streamline access to one source of truth for long-term services and supports information. So this includes compiling comprehensive information on LTSS resources, including eligibility, benefits, dates, locations, contacts, and then updating these regularly. And we're well underway in creating this. And then also to analyze the options, select and establish a web platform to share the one source of truth on this information. If there's more than one source, you really have the risk of it not being updated and current. So one source of truth is really important, and that was identified in our discovery process. Next slide. So this is about the alignment with the MPA. Next slide. This no wrong door, LTSS no wrong door system will align with the MPA and be embedded in it. There's a lot of similarities. They're both future facing. They rely on community engagement, and they seek to organize and build on existing programs and structures. Age Forward Together is the beginning of a stakeholder engagement process with groups that are organized around 4 goals: age-friendly economies, each journey is supported, reframing aging, and reducing barriers. So you can see how the no wrong door system would really be helpful in reducing barriers and making sure that journeys are supported. Next slide. So the other thing is, even though this ACL grant will end in August, this was really just to get everything going. So this, the No Wrong Door governance team will be working on this beyond the grant as well as DA. And they really look forward to your input and feedback as an important stakeholder in that process. Thank you. Any questions?
Well, I shared, this is Erin again, I shared with the commission this morning that we've really tried to take a realistic, practical approach with our development of the proposed plan, recognizing that there is a lot going on right now, and we'd like to try to make incremental steps towards really strengthening our No Wrong Door system, but we want to do so in a way that is practical and doable. So I'm open to any feedback, or if you have any ideas afterwards, feel free to share. Thank you.
Okay, thank you so much. Leslie, would you like to give an update?
Yes, so I will update on a few different things for Division of Aging and FSSA. I'll start with the Pathways and Health and Wellness Waiver transition that took place on 7/1 and continues to roll out. On a macro level, from a systems perspective, it went about as smoothly as a large scale rollout like that probably will go. It's not to say it was flawless, but kind of at the larger scale systems levels, things happened about the way that we had planned for them to happen. We did put in place a lot of different triaging tools. So as issues did come up and were identified, our teams have been able to address those as quickly as possible. All of those processes worked well from our perspective. And so we continue to address issues as they pop up. Certainly, if you hear of things, continue to send them our way so we can make sure we're addressing them. I do also have a couple of documents I can share with the board members via email after this meeting that just outlines the member resources and provider resources for who to contact if they are running into any issues. Those are all posted on our website, have been shared through various listservs, have been disseminated pretty far and wide, but want to make sure you guys have a copy of that as well. So we're continuing to work through those items, and then we'll certainly have more updates to come on both programs as we get through the first weeks and months of the program. Any questions I can answer on that? Yes, sir.
That was a very high level overview. Can you provide some more detail with respect to the transition, particularly on the pathway side? I know the what is it? The AAA's entity. What's the joint entity that they had come up with?
CCHI.
CCHI, thank you. Opted not to contract, and the MCEs were trying to negotiate with individual AAAs. So can you update us as to where that ended up? How many AAAs are providing service coordination, and have all three of the MCEs been able to contract for full coverage with respect to service coordinators, or are there still unfilled positions? So let me start there, and then we'll go.
Yes. So my understanding is that they have staffed up appropriately to meet their ratio requirements, case ratio requirements for service coordination. So did have to ramp that up pretty quickly, but we're able to hit those targets. The contracting discussions have been ongoing with the AAAs, and I think there's a couple of different spaces, and Kristen can probably speak to this better than I can at an individual level, but if she's here, and if she's, yes, she is.
Sure.
But There are some that were subcontracting with the MCEs for service coordination, and then there are some that have opted to instead become direct service providers and are looking to join provider networks for the MCEs to provide services to members. So that's a conflict of interest. You can't do both. So I do know that some AAAs have looked at going that path, and then I believe there are some that have done neither. They are all still contracted to do health and wellness waiver case management.
All of the AAAs
Correct.
as they were,
Yes.
yeah. When it was the A&D waiver.
Yes.
Yeah, but now the health and wellness waiver. So you're saying the MCEs have have been able to contract for all of the necessary service coordinator positions?
I don't know if they filled every position, but they have enough staff to meet the ratio requirements for providing service coordination to members.
So what's the early read on member satisfaction? Are members being contacted and having communication and?
So that's rolling out, right? So there's 120,000 people on Pathways. So they're in the process of contacting folks. They've contacted a good number of them, but that will continue to roll out over the coming days. We're hearing lots of positive things. We're also hearing some issues, right? And addressing those as those pop up, but have heard, I think I would say success stories and, hey, making connections with people that maybe didn't have a good understanding of what was available to them, or somebody going through a crisis at that moment, and they were able to kind of jump in and provide some assistance. And then we also have our member support services vendor that has gone live, who is there specifically to help members if they are running into issues with their MCE. That's an ombudsman-like program, so there to help members. And so they've been a really great resource as well to assist members and their representatives that they call in, and then also flagging things for the state. So if we see kind of a broader issue or a trend that we need to address, they've been helpful with that too.
And I read an article about payment problems that have already cropped up.
Are you referring to the nursing facility payment article?
Correct. Yeah, I'm switching gears,
Yes.
but I think it was the Indiana Capital Chronicle that covered that.
Yes, so we are working on those. The interesting thing about that is they have 21 days to pay claims, and we're not 21 days into the program yet. So we don't have late claims yet. Certainly, working through any issues that are popping up. We've got that claims work group that has been in place for the last handful of months that are continuing to work through things as well. So any issues that are coming up there are known, and we're working to address them, but we're not seeing any systemic issues at this point.
I mean, I'm looking at the article now.
Yeah.
It was Capital Chronicle, July 17. So what is that, yesterday?
Mhm.
Yeah. And I mean, the article is talking about concerns about systemic problems. So you're saying there are no systemic problems, and what I'm reading is concerns about all kinds of systemic problems. So like Paul Pieper, president of the Indiana Healthcare Association, was quoted saying, "We've got 3 different managed care entities, all with their own claims portals. As you're submitting your claims into each of their claims portals, it looks different and reports out different information at different times. It's trying to track, okay, is this claim pending? Is this claim denied? Is this claim rejected? Is this claim paid?" It sounds like I mean, maybe we're not 21 days into it, but obviously there are already concerns that have risen to the level of media attention.
I mean, we have not been seeing any systemic claims issues. Those types of examples, I mean, I think that's working in a claim system, I would say, is your claim is tracked through the process. So we, certainly have received outreach and have been in communication with our MCEs and with nursing facilities, and we're not tracking any like system-wide claims issues. Certainly we'll continue to take a look at it. As providers reach out, we look at that. We're in close contact with Paul Pieper and IHCA, and certainly those issues get brought to our attention as he hears them from members too, so we can look into them.
Yeah. Do you have any expectation, or has there been an expectation established as to how quickly claims will be paid once we pass the 21 days?
They have 21 days to pay the claim. So, I mean, it should be paid within 21 days.
So, I mean, to the extent that that there were claims created in the first week of the program, then based on what you're saying, you would expect cash to start flowing by next week at the latest.
That is my understanding, yes.
Okay.
Mhm.
Okay. Well, I appreciate the detail. I'm just very interested in understanding all the details of the transition as we go forward, and obviously, as I know you are, getting the issues worked out as they arise.
Yep.
So thank you.
Well, I have a question.
Yes, ma'am.
This started this morning and I thought, well, I'll finish my question this afternoon. Okay, we have a number of people on wait lists.
Yes.
Now, what I also have heard is the people on the wait list for Medicaid waivers may be they may be considered for choice, the choice program. Are they going to be put on a wait list for the choice program too? Are we going to have people on both wait lists? Is that what we've got going on?
They could be waitlisted on choice. It depends on their area because choice, it varies around the state whether there is a wait list or not. But if there's resources available to place them on choice and they meet the eligibility requirements, they could be on choice, or they could be waitlisted if there is a wait list in that region.
So what I'm seeing is I see people that are on the wait list for Medicaid waiver and then they end up on a wait list for choice. Now, are the people that are on the wait list for choice triaged? So if they have a higher level of care, they move up on the list?
I will look to Aaron to answer that question.
Good question.
Each AAA manages their wait list differently. A number of them are kind of first on, first out, and then some of them have different levels of prioritization depending on different needs, but it varies by area.
Yeah, so some people are going to be really waitlisted to be waitlisted. Yeah. Okay, just clarifying my mind what's going on.
I figured you were going to talk about wait lists
I sure am.
separately. Okay.
Yes, that's my next
That's why I
topic.
was holding
Yes.
off on questions
Okay.
about that. So
Sorry, I just.
No, you're
started
fine. I
off
A good
just didn't
segue,
with
yeah.
like,
I didn't want to miss the opportunity
How
to
far
talk about
does
wait
this go?
lists if we were already there, but I figured you were
Yes,
heading there.
I'll give a quick update and then yes, questions. So invitations for the first group of folks to come off the wait list went out last week. So just a reminder on the wait list for the waiver. So we implemented a wait list for the A&D waiver back in April of this year. We started what's called a new waiver year effective July 1st. So in addition to transitioning from one A&D waiver to the Pathways and Health and Wellness waivers, we started a new waiver year, which meant there were new slots available on the waiver. The wait list is around 13,000 people between Pathways and Health and Wellness waivers. We do have more available slots for both waivers, so we are inviting folks off of the wait list and onto the waivers. We determined that we would start by inviting 925 people per month off of the wait lists and onto the waivers. So that is 800 persons per month on Pathways, 125 persons per month on Health and Wellness. We landed on that number initially, looking at capacity across all points in the process to get folks onto the waiver. So there are various processes that folks have to go through to get through the eligibility procedures to get onto the waiver, and then monitoring how that flows, how well that goes. Are things getting bottlenecked? Do we have capacity to be inviting more people? How many people that we're inviting on are getting through the whole process, or how many maybe have, come up with other resources or don't qualify for some other reason. So that's where we've started, understanding that that's frustrating for a lot of folks and stressful because people are waiting to be connected to services. We wanted to be as transparent as possible, though, on how quickly we felt like folks would actually be able to move through these processes, because we can't process 13,000 people at once. It wouldn't happen. And then we felt like it would create a false sense to folks that they were going to be able to access services sooner than they would be able to. So this is a way to try and be as methodical as possible with this process. Continuing to keep an eye on it, staying in close contact with the AAAs as they begin their processes for face-to-face assessments, our internal teams that have to go through the eligibility functions, the financial eligibility process that folks also have to go through in order to meet the waiver requirements and receive a slot on the waiver. So this will be kind of a continuing thing that we obviously are monitoring closely, but that's where we are today at this moment. So invites went out last week. AAA's got their lists. They are working very furiously to get connected with folks and move through that initial process.
So this is 13,000 individuals who are on the wait list for either Pathways or Health and Wellness.
Correct.
And do you know how that breaks down?
Yes. Let me find information. We have, as of July 1st, we had 9,015 people on the Pathways waiver wait list and 3,762 people on the Health and Wellness waiver wait list.
3,762.
Correct.
So how many more people do you anticipate coming onto the wait list net each month?
We've been seeing an increased volume over the last couple of months. I think part of that is to get onto the wait list, you do a phone short form assessment versus doing an in-person face-to-face long form assessment to get through like the full eligibility process. So you can have those assessments a little faster. So we think some of it might just be we're able to kind of do those assessments a little faster, but certainly continuing to see an increased need as well. So not all of those people, we didn't start at 0 in April. A big chunk of those people were already kind of somewhere in the process, but had not gotten to the point of getting assigned to a slot. But we did see a pretty big volume increase.
Right.
Yeah.
Well, I'm hearing from more and more constituents who are caught in the process. You have been very gracious to correspond directly with one of my constituents. You were probably taken aback by my email response at one point in the thread where I said, in response to your email about it being months, I said months, I think, question mark, exclamation mark, question mark, et cetera. But I was just talking with that constituent again this morning. He contacted me asking for an update, and I said I was going to be at this meeting this afternoon, and I was sure that we'd be talking about it. But I just did the math, and I really don't want to report back to him because
That's right.
not 9,015 at an absorption rate of 800 a month, assuming no net increase, no one new coming on, means an 11-month wait, and 3,762 at a monthly absorption of 125 is a 2.5-year wait. That's more than months.
Right. I mean, it's certainly not ideal, right? I know.
I would use the word unacceptable. And I would hope you would echo that word. Because I can't imagine telling a constituent that you have a 2.5-year wait, someone who otherwise qualifies for the health and wellness waiver. Yes, thank you, Lori, especially after all the commercials, is going to have to wait 2.5 years
That's
to receive services.
So I
'Cause
do.
Let me interrupt real quick,
Yeah,
because the net effect and the conversation I was having with my constituent this morning is, in the case of his parents and in the case of many others, they'll never get the waiver. They will end up, in a skilled nursing facility, or in acute care, or, something is going to happen in the intervening time. 2.5 years later, some of these people will no longer be eligible for a waiver or need a waiver. And even with two different populations, but with the 11 months, same thing. I mean, we're going to end up with, let me phrase it as a question. Would you agree that with an 11-month wait, we will end up seeing a lot of individuals who are eligible for a waiver for home and community-based services instead go into skilled nursing?
It's possible. I think it's early for us to know that with any certainty. I mean, there are sometimes other resources that folks are able to pursue. You don't have to be on the waiver to be in Pathways. So we do have about 90,000 people that will be in Pathways and not to be on the waiver or necessarily be eligible for the waiver. They can access things like home health services through a home health agency. But certainly, yes, I mean, I think it understandably puts people in a tough spot, people like, your constituent. I think on the health and wellness, I want to be clear, and it's in the information we've shared out on this. So that will continue to be on a wait list. The wait list already exceeds the number of available slots on that waiver for the year. For Pathways, we don't today exceed the number of slots, but certainly as we continue to see a volume come on, we may end up in that spot in this waiver year as well. We're doing what we can to process people, like I said, as quickly as we can, understanding the different points in the process. Don't want to overwhelm
Right.
AAAs, don't want to overwhelm our internal staff. And we'll increase that number if we can. Yes, sir.
Well, I don't mean to interrupt. We knew there was already more pressure on the system because of demographics, population demographics. And now we've changed the system. And again, I appreciate everything that you've done and that you're doing. You've been very gracious in communicating with the constituent I mentioned, and I know with a lot of other folks. And let's face it, you inherited this. So congratulations. But, so I guess, I'm a problem solver, and I know you are too. We've talked about this in previous choice board meetings. At what point does the state apply for more waiver slots?
We need the funding to do that. They won't approve more slots unless we can say we have the funding, and part of the issue with where we are with the waiver is we don't have the funding to sustain the number of people that are seeking the waiver and the level of utilization they're seeking of services.
Is there not augmentation authority for that funding?
I don't know. What, you mean at the executive level, or do you mean?
Well, yeah, is there not authority to augment? I'd have to look at the budget.
I mean, we provide the Medicaid forecast, and that's how we report out what our Medicaid budget is and where we are with the forecast and our appropriation. So I think that's probably a question for state budget more than.
Well, and that's where I was going, but I
yeah.
should have had the budget in front of me, and I don't have it up on my laptop. But so where I'm ultimately going with this is we're headed into a budget cycle, budget session, just several months away. We have a transition of administration. So obviously it won't be the Holcomb administration making the budget request. So recognizing the transition that's about to occur, talk about how this unfolds without additional unnecessary delay.
I mean, there will be an administration change. We know there will be, right?
Right.
So we will be providing whatever information and data that we can to show here's where we are with the budget today. Here's where we're with the waiver and with the slots and with the utilization. Here's where you would need to get to fully fund this number of slots and that number of slots. And then leave it to the General Assembly to then tell us how much funding is going to be made available to the agency and then what we do with that moving forward.
Right. So again, where I'm ultimately going is for a number of years, choice funds have been used for waiver match, for the A&D waiver match. So do you anticipate additional pressure on choice funds to fund the additional waiver slots that are obviously needed? Have there been any discussions about that?
I don't know that that would be where it would go. I wouldn't say that it won't, right? And to your point, there will be a new administration, so that may change in January, even if that's not part of the discussion this fall internally. But I will say, you know, the choice budget probably pales in comparison to what will be needed in order to fund the number of slots that we need. So there probably will continue to be some leveraging of choice funds to pay for waiver administrative functions or ADRC functions, that sort of thing. I don't know that it would be leveraged specifically for the slot issue, but I can't say that for certain.
Well, it's already
until we-
pretty heavily leveraged.
It is and some of that is, like I said, for the ADRC budget too. So there's some, and we did reduce the amount going over to Medicaid last biennium by, I think, 5 million a year. So we chipped away at it a little bit, but I don't know the answer concretely to that, but like I said, it certainly wouldn't solve the problem. So I don't know if that would really be the direction we would go.
I'm just concerned that choice funding may be at risk, and the choice program itself may be at risk.
I think everything in this space is probably something we need to be looking at holistically, right? I mean, I think folks, to Dr. Burke's point earlier, folks that maybe can't access the waiver will be looking to choice, and knowing that the choice budget is also a finite budget. It will continue to strain that resource in some way. I think doing what we can to work with the AAAs and make sure we're maximizing the use of the choice funds that do exist. And then if the choice budget were to increase in the future, being able to leverage that in order to make sure folks can access services. But I think I think what we're seeing holistically is a strain on the need for services for older adults, and choice is part of that.
Well, as we've discussed here, and as folks have heard me say in other places, I think there's an opportunity for us to refocus choice dollars on other activities through the AAAs, especially prevention activities. And I'm in some conversations about that right now, and I hope that will be a legislative conversation come January, because I think there's an important opportunity there, and I would hate to see us miss that opportunity, because the AAAs have capacity to do more if given access to funding to support those activities. And I think choice is an obvious source of funding to support the type of activities I'm talking about. Again, with a focus on prevention. So I don't know, nobody knows how the transition is going to play out, but it just seems, I mean, looking at these numbers, I don't want to belabor the point, but looking at these numbers where we're talking about right now, all things being equal, an 11-month wait, up to an 11-month wait for the Pathways waiver, and up to a 2.5-year wait for the health and wellness waiver. We need to act sooner rather than later, and it sounds as though there could be more pressure as the wait list grows for each.
If there's any data that we can provide on choice as you're looking at some of those preventative services and some of that direction, please let us know so we can help support whatever you guys are looking at.
Well, I'd love to have that conversation. I mean, I think to me, it's there are a lot of specific programs that that we could look at, but at a high level, it's about focusing on the things that we know are most likely to lead to loss of independence and institutional placement. So, falls, medication management. We're talking about, in many cases, we're talking about simple and relatively inexpensive home modifications. And this is something that this board has looked at in past years. You know, this board provided leadership and advocacy for modernizing the choice program a number of years ago. I think we had legislation over maybe a 3-year period or so. And from like 2014 to 2017, somewhere in there, you know, when we modernize the way we look at income and assets, the way we count those, the cost sharing. But I think most important, the ability for AAAs to provide choice services to an individual with no current ADL impairment. And I don't think we have taken that nearly far enough since that legislation passed. It varies by AAA. Because you know, it used to be that you had to have 2 ADLs to receive choice services. And under the legislation we passed, if there's I think the way we phrased it was something like a risk of loss of independence to an individual, then they could receive choice services with no ADL impairments. So the AAA could go ahead and do the home modification, for example, for somebody who was at risk of losing independence, not somebody who had already lost independence. And to me, that's that's where the conversation should start, is how do we do more of that? You know, how do we do more outreach and more early intervention to, you know, to prevent the fall that that causes the injury that leads to loss of independence. You know, rather than throwing services at someone after they've already suffered a fracture, you know, how can we help prevent the fracture from occurring? And I think, you know, choice presents a lot of opportunities, especially given where we are right now with the transition to MLTSS and needing to redefine the role of the AAAs going forward.
I agree with you wholeheartedly on the preventative direction for things. So if we can help again with providing data or anything like that as you're having those conversations.
Well, I won't take any more of the board's time, but I will certainly follow up with you. And you know, I don't know whether the gubernatorial transition creates an opportunity for you guys, you know, for the division to be more engaged in that, because obviously there's no Holcomb administration agenda for the 2025 session. So maybe the Huckleberry agenda will
Looking at our legislative director, I don't think that'll be the way we'll go, but if I can help provide information as you guys are looking through that, I think that's where we can be supportive on providing the tools that you would need to evaluate and take to the General Assembly, you know, what you guys think is best for
I
the
didn't
board.
see that Mr. Habig had entered the room. He got the alert that I was talking. All right. I'll be reaching out. Lots of good stuff we can do. And I want this board to get back to where we were when we worked on that legislation a number of years ago, because this board played a very important role in that. And I think there's a role for the board as a whole and individual board members to play again. I know Jim remembers that, and there are still some other folks around who were involved. So thank you for the conversation.
Speak as well, just, you know, again, as a recipient. So the reason I wasn't at the last meeting was I had my 4th joint replacement. So my first one was in 2021 when I was 45, and this one came in at 68. The change in the medical system and what has happened in, you know, in 21 years ago, I had home PT and home nurse and all of that. And this, you know, I had a beautiful site from Lakeshore Drive having surgery, but it was me and my husband, and get home and take care of you. And going to PT immediately after surgery with many people that were even of more age than myself, there's a great fear to disclose that you've had a fall. You know, I could visually see some of my fellow rehabbers that they had a fall and they wouldn't disclose that to their physical therapist because there was that fear that what does that mean next is gonna happen in my life? And so, you know, my husband gets so offended every time he goes to the doctor and they're filling out those, how many times have you fallen? And so I said, we all just become liars because we just say, oh, I haven't fallen. So I think that prevention and to somehow in between take away the fear that comes along with that you may fall, but then this is we're gonna be able to have systems that will assist you in the future. So thank you, Ed, for continuing to want to do that.
And you've got to stay involved even if you move away from the choice boards. Remotely, you can zoom in.
Anything else for Leslie?
I had a couple of other quick updates, if that's okay. So wanted to give an update on a couple of other Division of Aging items. Adult Protective Services. Just wanted to give a quick update on the status of that program. So Adult Protective Services historically has been administered by the prosecutors around the state. We did get notice from them last fall that they would not be renewing their contracts effective July 2025. So we've been working over the last several months and are going to continue to work for the next several months to determine a sustainable direction for that program. We did an RFI or a request for information in May to get information and feedback from potential vendors for administering adult protective services. Got a lot of really great information. Those of you who know the state procurement process know that generally the next step after you do an RFI is to do what's called an RFP. So put it out for bid to potential vendors. So we're evaluating next steps leading up to that potentially, and then doing some stakeholder engagement. So meeting with current APS director, staff, prosecutors, meeting with the AAAs, and reaching out to other stakeholders as well in the coming weeks to get feedback on the current system, challenges there, and then have brought alongside some national experts to help us with looking at best practices of other adult protective services programs. So as we're putting forth kind of a sustainable model that we're using best practices as much as we can as we're building that forward. So just wanted to share that update.
Leslie, when does that contract end for prosecutors, or has it already ended?
It ends in July 2025.
Okay, thank you.
Yes,
So fiscal year 26 is what you're really looking
correct.
at. Got it.
Yep. Quick update on the multi-sector plan for aging. So that's our 10-year strategic plan for supporting aging Hoosiers. So we had our kickoff meeting with lots of stakeholders and interested folks back in May. We have formed work groups focusing on a handful of different areas for that plan. And those work groups start meeting next week and have meetings scheduled out through early fall to help inform those recommendations for what the strategic plan should include, with the goal of having a draft plan before the end of this calendar year. Part of what we will be doing with that plan is building in measurable objectives as well. So it's not just a plan on paper, but something that we can measure progress for over the years to come. So I'll continue to keep you all updated on that, because choice certainly as one component supporting older adults in the state will be important for you guys to be informed of kind of that overall strategic plan that we're working towards as well.
What's the timeline on that?
So we hope to have the draft plan before the end of the calendar year. So the work groups meet through, I think, the end of September to help develop what the different goals will be for the different areas of focus. And then we'll have that put together as a draft strategic plan.
Would it be available for the November meeting?
Possibly. So our goal right now is end of October, but I want to give us a little bit of wiggle room just in case. So perhaps though.
So how many work groups are working on this?
There are 5. So there are 4 different focus areas and then a specific data and research work group that will help inform the other work groups as they identify if they need, additional information, want us to look into what other states are doing in certain capacities or what resources might be there. And then as we're thinking about what are those objectives and how do we measure them over time, will also help develop that work as well. So we can figure out kind of what those metrics will be.
And each work group has a diverse array of stakeholders, I assume.
It does, yes. So we have we were very intentional of trying to invite people from multiple sectors, hence multi-sector. So we've got great AAA representation. They were really enthusiastic. But we've pulled from public, private, nonprofit sectors as much as we can. So
You have the timing is interesting, right? Because again, it's the beginning of a gubernatorial administration. So we're going to have a 10-year plan that
mhm.
may or may not coincide with what the administration's
Our hope,
objectives are.
yeah, our hope is that by bringing together the stakeholders that we have, that we're going to put something together that's well-informed and evidence supported, that would be able to be supported by multiple administrations over the next 10 years.
Sure.
So can't stop the work, so we're
No,
gonna,
I'm not
yeah, we're gonna
saying
keep
should.
going with it and hopefully they will, but it is also, it's not meant to be a static plan necessarily either. So as new issues come up or new things are identified, or there could be shifts in priorities, that can also play into the plan too. for
Yeah,
sure.
no, I very much appreciate the work you and your team and the work groups are doing. I just wanted to have a little explanation of the process for those who may not be familiar. I think it's always about communication and transparency and alignment.
Mhm.
And as you wrap up the plan, I hope there will be opportunities to get it in front of legislators.
Absolutely.
Obviously, the new administration, but with budget session approaching, I think it's critical that legislators be educated regarding the plan and hopefully see opportunities for legislative alignment.
Yes. And so we do, our intent is to reach out to legislators sort of as we go through development too, so we can get feedback as we're developing the plan as well. So more to come on that in the coming weeks.
I'm happy to provide feedback, so feel
I
free to
appreciate
reach
that.
out.
Yes, I will. And the last very quick update. So we have the Dementia Care Specialist Program that provides a dementia outreach specialist in each AAA around the state to help connect individuals and their caregivers with resources for persons living with dementia and their caregivers. Part of the legislation that created that program also created funding for a statewide coordinator position, and we have hired that person. So Kim Wood started with us last week. So just wanted to mention that in case there are folks that are working on anything, particularly in the dementia space, you may see her name start to pop up on things, but we're very excited for that and for the collaboration with the AAAs that she'll be doing to continue to bring that program to life and build it for us. So just wanted to mention that. And that is all.
Are there any other questions for Leslie? Okay, thank you. Thank you. Erin.
Yes, thank you. I'm just going to provide some brief updates on the choice program. We've been talking about waiting lists earlier. The current choice waiting list is 2,434 individuals. I think there's 2 AAAs that do not have a wait list, and the rest are of varying sizes. This is about 200 more people than were on the waiting list in May, and it's about an 82% increase from this time last year. The reason noted for the wait list across the board is lack of funding. We have heard anecdotally that provider shortages are creating some challenges, but at least our data is showing from what is indicated on the waitlist records in our system it's the funding. A few months ago, we amended the choice grant agreements to reallocate funds. We had 2 AAAs that were projecting to underspend their allocations, and we had 8 that had requested additional funding. So we reallocated funds. We don't yet know what the end result, even though the state fiscal year 24 has ended, we won't see those final claims until the end of next month. So we're not sure yet where we're going to end up with any potential reversion. We generally see an uptake in spending at the end of the state fiscal year. So I should have an update for you on that either at the September meeting. If not, then it will be at the November meeting when we talk about the state fiscal year 24 choice annual report. I wanted to share just in full transparency that our state fiscal year 25 grant agreements with the AAAs for the year that started July 1, they're still working their way through the process. We experienced some delays related to eCivis, which is a new statewide grants management system that SBA, State Budget Agency, is implementing, and it required us to change the way that we are handling the required state match portion for our Older Americans Act funds, and those funds are part of our state grant agreement. So we ran into a lot of delays. We've sorted through all of those issues, and the agreements are finally moving well in the process, and we expect those will be out for signature soon. The first claims against the 25 grant agreements aren't due until the end of August, so we're still in an okay window, but we're really, really, really pushing. The contracting process is long. We're long involved. We're one small piece of it, but we're doing what we can. So I just wanted, in case you hear anything, to share that.
Contracting, sorry.
Their choice funding for 25. Their grant agreements.
Right, but I mean, isn't that just basically new dates on the 24 agreement?
Yes, but it's a 4 to 6 month contracting process.
Welcome to state gov. I mean, and I know that has nothing to do with you, so my next comment has nothing to do with you. But that is ridiculous. Because it literally is, and Kristen Lais can jump in and correct me if I'm wrong, but it literally is changing the dates. I mean, it's all the same stuff.
The outlet amounts are different.
The amounts are, changing the amounts and the dates, but I'm saying in terms of
Yes.
the functional parts of the agreement, you know, what services are being provided and how they're being provided, and all of the nuts and bolts are basically the same from year to year, correct?
Yes.
Right.
Mhm.
Yet it takes 4 to 6 months.
So are they expected to be doing work at risk then? Is that what they're doing?
Yes.
So just cross your fingers and hope you get paid. Yeah.
I hate to ask this question, but do they have the capital to be able to finance that and provide the level of service needed for the next 6 months?
Well, they wouldn't be submitting claims for this period till the end of next month anyway. So our hope is they will have everything they need by the end of August to be able to submit the claims when they expect to submit the claims.
Okay.
In the past, when we have run into delays, we have heard from the AAAs that they've run into issues. So thank you.
Yeah, I'm sure there are severe cash flow concerns right now, if not yet actual cash flow issues.
And I know it's not unique to the Division of Aging.
No, but the AAAs just had a hit because they were providing case management, and they were getting weekly, or well, I'm not in weeds, but timely payments from Medicaid. Now that's gone.
Well, it's more than a hit, it's a body blow, but yes.
Yeah. So this is really, I don't even know what word to use.
Untimely.
Oh, you're so kind. That's why you're a politician. But anyway, very good. But it is unacceptable. You can't run a business, you can't run an organization on fumes. We said that this morning. It's not possible. So this needs something.
I mean, this is obviously something that needs a legislative look, because it shouldn't take 4 to 6 months to, I'm not asking you to comment, but it shouldn't take 4 to 6 months to update a very straightforward agreement. I guess, with respect to the wait list though, 2434. So what's the, you may not know this, so I don't want to put you on the spot, but what's the average time on the wait list at this
We
point?
don't have data on that. We can try and get it out of our care management system. We have run into situations where just without getting too in the weed, it's just difficult.
Yeah, I just thought part of the new system, when we talked about this several years ago, it was going to allow us to capture things like that we hadn't been able to capture before.
It's been a challenge.
And that's a system challenge or a data input challenge?
I think a combination of both.
Okay. Well, and I was going to ask about breakdown of what people are waiting for, because I know we always have some people who are just waiting for case management, right?
Typically, it's actual in-home services on the wait list.
So the 2434 is all people waiting for actual services,
Mhm.
not just case management.
Correct.
Well, that's even worse.
Yeah, they're waiting for Medicaid waiver services and then they're put on the choice wait list. Wow.
And
Well, go ahead.
God, I was just gonna say, we will try to keep an eye on, because we don't know what the impact of the Medicaid waiver wait list is going to have on choice. So we'll try to keep an eye on that. It's possible that individuals will remain on choice longer because they don't have the waiver to transition to.
Sure.
Or, you know, at
And
this
that's-
point, don't know what
But
it's
that's a
going to
concern
be.
that I think we discussed at the last meeting, because that puts additional artificial pressure on the choice funding. Essentially, in those cases, using 100% state dollars to provide a bridge to waiver services. So, well, thank you for what you're doing. And seriously, I mean, now more than ever, what you're doing, and Ms. Huckleberry, what you're doing, and others on your team is more critical than ever because of the gubernatorial transition that is approaching. You know, we need continuity, and I just appreciate everything that the two of you and others are doing to provide continuity. I hope neither of you is joining the growing exodus.
We're here.
Yeah, in here.
Well, seriously, thank you.
Thank you.
I'm so sorry.
Yes.
And I'm a bit naive on some of these, being new to the board. So if this idea or question is way out of line, please let me know. I am sure that these wait lists keep you all up at night. Like I have no doubt about that. I was relatively involved with DMHA's process to reduce their wait list for folks awaiting assessment for a competency to stand trial. And just interested in whether or not you guys have chatted with them on what they did to alleviate those wait lists, and if that's a possibility, an avenue that you could explore for some of these.
Yes, so I was actually the executive sponsor for that project for our agency, so I am pretty well versed on what we did for that. There were, I would say, some significant differences between the challenges with the Detroit wait list and the state hospital wait list, primarily being funding. We had funding available through DMHA to be able to put forward some new and innovative solutions to address the wait list. There were some other things that we were able to do that weren't necessarily tied to funding, regarding, you know, recruitment and retention of staff, things like that, that helped us open up some of those state hospital units that historically we hadn't been able to staff. We do actually have a waiver eligibility work group we're working with the AAAs on right now that we started last fall. And one of the components of that work is looking at professional development and workforce challenges that they're facing. So that's a conversation we're having with them kind of on the EDRC side of things a little bit, just to think about what are the challenges they see as a network and then see in individual areas and how can we help with that. So I think there are some lessons that certainly we can learn from that work with the state psychiatric hospitals. Lots of unique things about that wait list. I think that doesn't necessarily translate over to choice, but if certainly if we got additional funding to help with choice at some point, that would kind of, we could certainly take some lessons
Yeah,
learned for
and
that
I
too,
think
for sure.
specifically for those that were in the county jails
Mhm.
waiting for that assessment, they found new ways to contract, and there were some legislative solutions that went through as well that helped speed up that process for folks to get them off that wait list with a resolution.
Yes, so there was legislation passed last year that provides some flexibility for judges to dismiss misdemeanor charges for folks that have a TBI or similar diagnosis that was the cause of their competency issues. Some certification legislation that we work towards as well. So I think part of that too, though, again, we were able to contract with entities that could go into the jails too and help with that restoration process. But we had additional funding available to be able to pursue some of those contracts. So
Opened up contracting process is really, I think, pretty monumental. It added service providers to the list that wouldn't traditionally be able to do that.
yes. So that whole alternative restoration path we were able to open up was really significant and really helped allow us to build those different partners across the state and also help the state hospitals be able to focus on those folks that really probably specifically needed a state hospital bed versus others that maybe just need some additional help and assistance, but could be in a different setting and still receive appropriate services. So yes, it's a great project. So glad to hear that you guys,
It's successful.
yes, it was great. Yeah.
Definitely.
Are there any other questions for me? All right, thank you.
Thank you.
Good afternoon, everybody. I'd like to especially welcome our new members who are jumping right in. We really appreciate great questions, by the way. You can, I mentioned earlier, you can blame I4A and some of the legislators in the room and some of the members of the boards in the room that requested the additional members join the board. So you can blame all of us, and we really appreciate your commitment and willingness to serve and to offer your expertise and perspective, and just really looking forward to having everybody on board. I did this at the Commission on Aging meeting as well, and particularly for some of the new members, I just really wanted to highlight the work the AAAs have done over the last 6 months to help effectuate all the transitions that have been happening with the Medicaid strategies related to the Medicaid budget shortfall, waiting list, legally responsible individual transition, at the same time having to pivot related to role within managed care and the disruptions that cause for their staff and agencies, and most recently now being tasked with kind of this influx of Medicaid waiting lists, which is a good thing, but it does create a significant amount of stress on these organizations. And, quite honestly, they've kind of been managing through crisis the last several months. So they've kind of done a hero's job in sustaining their mission and services. And so I just really wanted to kind of give a shout out to the AAAs on that. They are dedicated to doing the best thing and the right thing for the consumers they serve and the communities they serve. And but they also have a responsibility for sustaining their missions in the community, and they are working diligently to do that. in the face of all these changes as well. And to kind of highlight the effectiveness overall of our networks, I wanted to share good news with you. In that at our national conference last week, Indiana AAAs and personnel were recognized with multiple awards. And this is in a network of more than 650 organizations nationally that our staff and our network rose to the top. We were selected to provide multiple presentations from those that were submitted. Connie Benton Wolf at Aging in and Home Services was recognized with the prestigious U.S. Aging President's Award for the leadership that she has provided to the network, both to her organization locally, to our state and nationally. In addition, there are Aging Innovations and Achievement Awards that are presented to multiple organizations. Aging in and Home Services was recognized for their work on the Community Care Hub of Indiana for that. And that was among 38 programs that were recognized nationally. There is also kind of a Care Manager of the Year award that is sponsored, and Richard Gaidu of Socoa Aging and In-Home Solutions was recognized with that award. That's only one award that's provided nationally. And it really speaks to the regard with which Indiana is held among its peers nationally. And in addition to that, our network has been instrumental in influencing the legislation writing, I guess is the way to say it, for the Older Americans Act. Senator Braun is one of the 8 senators who are working on that reauthorization language this year, primarily in his role as ranking member of the U.S. Senate Committee on Aging. And as such, we've been working hand in hand with our national organization to express both our national and state priorities, meeting with their staff multiple times, vetting, providing language. And as part of that, Senator Braun wanted to ensure that Indiana had good representation in front of the actual Committee on Aging in DC. And after talking with a number of AAA executives in Indiana, Senator Braun extended the invitation to Laura Holscher to provide that in-person testimony. And we mentioned this at our last meeting, but our new members may not be aware of this. And so your packet includes some information on the success of that hearing. But even that came out of our national organization. Laura was selected not only for her lengthy experience with generations, her experience in serving rural communities, and serving our state network, but she also covers Senator Braun's hometown. So I think that there was a real affinity there. The other thing I've included in your packet, again, just to highlight the leadership our group provides nationally, is a thank you from the U.S. Aging Policy Chief to Laura. I was CC'd on it, which basically gave Laura her MVP award of all-time witness people. And she wasn't just talking about this year, she was talking about of all the years she's seen people testify. She ranked Laura as one of the most effective. And, so that's kind of one of the best things I can share with you. We're seeing a lot of news and you've heard stories about how difficult this transition has been for AAAs, but this is still what we're doing. And we're doing it well, and we're recognized for it nationally. So thank you for letting me share all that. There are in your packet, some additional, federal things I want to highlight, including that, of about the 8 organizations that were recently approved as new guide model participants. This is a new model for dementia care in Medicare fee-for-service that mirrors a lot of the work we did and have been doing on the with the aging brain, healthy aging brain community, which includes care management, caregiver supports, caregiver coaching, primarily service coordination, primarily focused on persons with dementia, or focused solely on persons with dementia. And of those 8 models, AAAs are involved in half of them that I'm aware of. Fort Wayne it has a regional initiative. Statewide, were involved or written into the IU health system application. Eskenazi was approved and SACOA is involved with that. There's in Representative Clear's district, Lifespan Resources is partnered in the community. And I need to check in on some of the other ones that I wasn't aware were going in, but you can bet we'll make sure that our AAAs are reaching out to the other approved organizations to say, hey, remember us and let us help you implement those guide programs. Similar to how the state is conducting a multi-sector plan on aging, the federal government is doing something similar on the national level. And they're calling it Aging in the United States, a strategic framework for a national plan on aging. And that's included in the packet that we sent. That packet, that article is fairly detailed. They are accepting public comment on that framework through September 19th. And I think the information on how to provide that public comment is in the packet, but you can always just Google it and it comes right up. It's kind of in response to a lot of the work states were starting to do around multi-sector planning. And what's interesting is that they drew from some of the state's experience in multi-sector plans. So you'll see, based on their framework, a lot of congruence with the work Indiana has been doing. Honestly, for the last 2 or 3, is it 2 years or 3 years when you got into the Learning Collaborative on multi-sector planning?
It was 2022.
2022. So I hope you'll take a look at that just to kind of stay in touch with what's happening at the federal level. The federal House released its proposed Older Americans Act budget for federal fiscal year 25. However, this is just one proposal. We still need to see the Senate. We still need to see how that lines up with the president's proposals. It was a mixed bag. There were increases in parts of the Older American Act and some inexplicable decreases. So it kind of, in some sense, washes a little bit. But the main takeaway from this is that we can expect to actually be on a continuing resolution, which I think which we might still currently be under, all the way through after the election into the beginning of January. So we really won't see any appreciable change in appropriation amounts until the new administration comes in at the federal level. There were also a couple of Supreme Court decisions I want to draw your attention to that could have impact on the work we all do in healthcare and long-term services and supports. The first was the what they call the Chevron decision, which seeks to limit the power of the federal government to promulgate regulations that implement or go beyond intent of legislation passed by the federal government. And most of you are aware that most of our healthcare system relies on those regulations for nursing home regulation and, health and safety and what the fees are going to be in Medicare and on and on and on and on, and waiver programs. And so, depending on the kind of actors that start filing additional lawsuits because they don't like this or they don't like that, we're just going to have to pay attention to all that going forward. You may recall that I've made you aware of lots of different final rules that have been promulgated affecting APS, that the Older Americans Act final regulations were promulgated. Other things that have been coming out of this administration as final rules. It's like, okay, so what happens to those? So we're just going to have to pay attention going forward and understand the potential consequences of that Supreme Court ruling. So there's a couple pieces of commentary on there and the potential impact on health policy. In addition, there was a Supreme Court decision that sided with an Oregon city, allowing them to continue to criminalize public sleeping, or basically homeless people. And this is incredibly, and I'm not suggesting that there have been communities in Indianapolis that are going, or Indiana that are going down this path, but we need to watch out for it because the fastest growing population of homeless people are older adults. And we continue to face those issues in our ADRCs every day of people looking for housing. It's a statewide issue for persons of all ages. And at least at the state level, our state has only been willing to address infrastructure and developer subsidies rather than increasing direct housing assistance or dealing with the landlord-tenant issues that involve the eviction crisis and that kind of thing. So there's commentary in there about kind of what's happening nationally around AAAs and our work in housing and homelessness that is provided by our national association. Also included some additional research updates that came out recently about housing affordability nationally and in Indiana. And finally, in your packet are results of survey data. Annually, ACL publishes a profile of older Americans. So the 2023 profile was just released, which is included in there. United Healthcare annually publishes kind of a cost of care analysis, which is informative and has state-specific surveys. And so kind of that overall document, as well as the Indiana result, is included there, as well as just some other issues that I thought were interesting, calling attention to increased incidence of fraud related to older adults, some guidance and information that AARP put out related to real estate fraud, information about recent research on older adults living in poverty, et cetera. So I'll stop there and see if there are any questions since we're at time.
I have questions. Thank you for all of the information. As always, you talked about the Chevron decision, but I don't think you mentioned its specific potential impact on the staffing. And I'm wondering where the long-term care staffing rule, and I'm wondering where things stand with the
So
long-term care.
the packet
staffing.
was so big that I left out commentary on long-term care staffing.
Well, you did, because it's 151 pages long, and I searched for the word staffing and found it exactly once.
Right. Well, I left it out.
Last
Yeah.
time it was a focus of the packet. So
Yeah.
I was actually looking forward to an update on the staffing rule, but particularly in light of the Chevron decision, because I know the industry, the long-term care industry, I think in late June.
Filed a lawsuit.
Right
Yeah.
right after the
Mhm.
Chevron decision called, I wasn't aware of the lawsuit, but I know the industry had originally called for a pause in the implementation of the rule. Did they file suit?
And then this would have been at the national level. I thought that their national association did, but I'll have to go back and double check on
Well,
that.
regardless, I know,
Yeah.
I know they saw it as an opportunity to
So
put the brakes on.
I will forward to you. There was analysis, I believe, done by the Kaiser Family Foundation on and it was a national look state by state as to the number of facilities that could actually meet the new staffing guidelines.
Okay.
And it was kind of, I mean, nationally, it was kind of abysmal. So that's what I have for you. I do not have updated information as to any direct impact of that Supreme Court decision on the staffing regulation, which is folded into a larger Medicaid regulation that came out. So there were more parts to that regulation.
Sure.
So I do not have information about that.
So you're saying that KFF did an analysis state by state, facility by facility?
I don't know.
Okay.
Their methods will describe what
Okay.
they looked at, but CMS, I mean, on, that Care Compare website, CMS has the staffing ratio information based on the things that the reporting that facilities have to submit, as well as the claiming data, et cetera. So, they could have just, pulled the CMS data on that.
Well, will you please send all of us both the KFF analysis and the link to the CMS staffing
Regulation?
tool, one of the tool to look at the staffing on the CMS site?
The Care Compare website?
Yeah.
Sure.
Okay. Is that, I mean, that's a subsite of CMS?
It is,
Yeah.
and they keep expanding it to include other kinds of services, but you can search by zip code on nursing facilities, and there are various kinds of data points, and I believe staffing ratios are one of those data points.
I haven't dug into any of that lately, so I'm just interested to
Mhm.
see what's available right now, and especially in context of the KFF analysis. I'm very
Mhm.
interested in that. I wanted to flag one other thing, but I think Mr. Sipe has left us. Is he still on? No, I only see two people. So maybe you can
I'm here.
answer.
Oh, hi, Jake.
You're
Hello.
there.
I also, with the housing piece, before you ask, I
Yeah.
did want to call out, and quite honestly, I have a question for Jake as well. Jake, can you comment as to the expected release date of the housing study involving needs assessment for older adults, age
I
restricted?
don't know. I know we're working closely with Division of Aging, but I don't know the release date now. I can follow up and find out though.
Okay, that would be awesome. Representative Claire, go
No,
ahead.
you're fine. Jake, do you have Kristen's packet in front of you?
I don't. I think I just have the agenda. Let me look.
That's okay. I can read you it's short here.
Okay.
So it's on, pages aren't numbered. It's on the 36th page of the 151 page PDF. So the page is numbered 25, but it's actually page 36 of the 151 pages, if that makes sense. And it's talking about the 4 domains that were presented as part of this
National framework.
national framework. Thank you. It says multiple systemic barriers limit development of new affordable housing that could include older adults. These include state and local zoning and land use policies, particularly in urban and suburban regions, as well as state priorities for use of federal housing resources and credits. For example, only 7 states set aside a portion of their federal housing credits for affordable senior housing, while 37 states award points to housing development projects that specifically serve older adults. So I was just curious where we fall in terms of set aside or awarding points.
Yeah, we used to have a set aside. We removed it a couple years ago. We were receiving more than sufficient number of applications for senior housing, which could be defined as 62 or older or 55 and older. So we have not, we've had a really good application pipeline of developments that are targeting age-restricted housing. So we removed that as a set aside. So we haven't incentivized it or prioritized it just because of the volume of applications we have been receiving. We monitor that every year just to make sure that that volume's still there. And I think I can have to look at what we awarded for this year. We made our awards. Applications are coming in next week. So I can take a look and see how many applications we received that are dedicated for I would say, age-restricted housing.
Could you plan to report on that at the September choice meeting, please?
Yes, sure.
And this is a great example of why the AAAs were on target by advocating for making sure that housing expertise is included in the commission and the choice board. So thank you.
You had a part in that legislation, so thank you. So, and thanks to, obviously, Jake for being part of that. I will say, you know, based on the things that we watch in terms of the tax credit applications coming out, it's, you know, there's a good percentage of each award rounds that are age restricted. It seems to me, you know, there's not just like 1 out of 20. It's like, you know, upwards of a third, it seems to me, each round at least. And the other thing is that, you know, we've had area agencies on aging involved in recent applications that have been successful in different communities. One that opened with Thrive Alliance down in Seymour a couple of years ago. Hoosier Uplands is usually pretty successful at converting things like old schools into senior housing, things like that. So from a tax credit perspective, I think that we're pretty well supported by what IHCDA is doing in that area. You know, we can always use more direct assistance funds for rent and mortgage assistance, as well as addressing the landlord tenant concerns.
Yeah, and my question or request wasn't a criticism of IHCDA.
Yeah.
I think Mr. Sipe and his team
Yeah.
do a lot of
Yeah.
amazing work. I always enjoy working with them. I just think it's important now that we have incorporated housing more directly into the work of the choice board, that we look at some of these things. And based on your packet, I thought that would be a good thing to take a look at. There are other places in your packet that talk about the rent issue. So I'm glad you raised that, because I think that's something else that we should be talking about. You know, it's great when it's great that we're seeing a lot of applications for funding for construction of new senior housing or adaptive reuse of existing buildings into new senior housing. But I think the rent issue is really important as well, because obviously we have a lot of seniors who already have a unit, and that unit is becoming less affordable. And I think that's part of what your packet raises as well.
Yeah, I think what's really important to pay attention to over the next several months is that there is a component of the multi-sector plan on aging that should be seriously addressing housing concerns. And so we're hopeful that embedding those kinds of issues within a much larger strategy will result in some success perhaps we haven't seen by taking other advocacy routes. Okay, thank you. All right, anything else?
Any other questions for Kristen? All right,
Thank you.
Kristen. Thank you for all the hard work for the AAAs. That's wonderful to be represented so well on the federal level, and recognition that they so deserve, just as Representative Claire and Dr. Burke said, you know, they're taking a lot of hits. And it's wonderful to know that they're recognized professionally. And we know that we have had a series of articles in the past in the newspaper of how Indiana needed to rise up and they're certainly showing that we're rising.
Thank you.
So thank you. All right. Well, we've come to the end. I'm sorry that we're over a little bit, but it's good weather out there. It was good traffic. Are there any other comments or concerns to come before?
I just want to say thank you, Lori, for all the work you've done on the Choice Board as well as on the Commission on Aging. So
Thank you.
wish you well.
Thank you.
Yes.
Anything else? All right, I entertain a motion to adjourn.
So moved.
Thank you, Stephanie.